So for our next talk is going to be Dr. Marcel Maya, who I know quite well, and it's going to be fun listening to his talk. We might have some of the same slides, I guess. And he will be talking on the current approach to cranial and spinal imaging. Thank you.
Thank you very much, Wouter. Thank you, Connie and Wouter, for inviting me. And it's a pleasure to be here to speak to all of you about craniospinal imaging. Obviously, CSF leak is not a mystery where it is coming from or how to deal with it if it's a complication of spinal surgery, which is dreaded among some circles. And it's quite obvious. Nevertheless, you can see in imaging of MRI spine, routine sequences show that large collection in this patient, which is obvious on the myelogram with a typical tear at the time of surgery on the right side at L4-5. But we're here to talk about the spontaneous intracranial hypotension and leak, and let's discuss the imaging. I know it was shown this morning, but I want to just go over it briefly because it has some relevance and how it affects the imaging. And the cranium is a rigid structure, and brain and blood CSF are all in an equilibrium, and when one of them goes down in volume, CSF or blood, since brain is not collapsible or expandable, the other one must adjust. So as CSF goes down due to a CSF loss, leak, there's expansion of the blood in the veins and venous sinuses. We heard this morning from Dr. Silverstein, and the question was whether it's hypotension, low pressure, or hypovolemia, or neither of them. Maybe a compliance issue. But the main problem is decreased pressure, but pressure can be normal, as we heard. Everybody has headaches, except that some people don't have headaches and still have this condition. And many people have abnormal MRIs with enhancement, etc. But in some people, MRI may be quite normal. So let's go to some of the findings and how they bear on the cranial MRI findings. On your left, you'll see a normal drawing, and on the right is the CSF leak or hypovolemia condition. And as you can see, let's see if I can move this. There's expansion of the sinus. There's development of subdural fluid. And there is enlargement of the pituitary. There's inferior descent of the tonsil, optic chiasm distorted, and the pituitary is hyperemic and enlarged, plump. Same thing can be seen in the spinal canal, where the epidural plexus enlarges, and there may be fluid collection ventrally. Stated in a different order, brings up this one, which is quite easy to remember, SEEPs for subdural hygromas or hematomas, enhancement of the meninges, the pachymeninges, the dural enhancement, the enlargement of the veins, dural sinuses, pituitary engorgement or hyperemia, and brain sagging. We're lucky in 2017 we have an abundance of imaging available to us, maybe too much imaging, and the government is trying to cut it down. But in this area, I think we need imaging. And radionuclide cisternography is an older imaging technology and modality, which is coming out of favor. The main imaging modalities, the brain MRI, spinal MRI, and enhanced by the myelography MRI without intrathecal contrast that we do for these patients. Intrathecal enhanced MRI has been advocated as a possible solution to slow leaks and got favorable reviews, but we'll talk about it. It may not be as great as it was first advertised. We also have conventional myelogram, which is under fluoroscopy. You stick a needle and then get x-rays, fluoroscopy, and then send the patient to a CAT scan, get a myelogram in half an hour or so. Recently, we've had advances with fast myelogram to eliminate the interval of contrast introduction and scanning so that we know what's going on. One of them is dynamic CT-guided myelogram, where the puncture is done in the CT scanner and rapid sequences are obtained in the CT serial. And the other one is DSM, digital subtraction, which requires a angiography type of equipment, and it's done under with rapid filming. Radionuclide cisternography, it's with CSF leak, you have a paucity of indium-111 over the convexities. You can see up there, there's not much accumulation here. And then you can see the paraspinal collections down below, which are the diverticulum or cyst. It's not very good for localizing the site of the leak, but it may be helpful in certain conditions when all the clinical data and presentation doesn't make sense, it's not very convincing, and you can do this test. MRI of the brain is bread and butter, the most important one, obviously. And this is an example of a patient who does have some pituitary hyperemia, but classically has that dural contrast enhancement over the top and subdural collections, which are slightly different in signal than CSF. These are not hematomas, they're collections. This is a different patient and was altered and subsequently in a coma. And here you see the full-fledged brain sagging and descent of the brain structures, the mammillary bodies, the tectum, tegmentum. It's one unrecognizable mass that is at the level of the brainstem. You see the pons is enlarged and deformed. The cerebellar tonsil is not very much descended. However, the optic chiasm is quite abnormal. It's flattened and drooping back. So this contrast is given, and you see the bilateral dural enhancement, and in addition, mild subdural collections. This is a different patient who had who was transferred or referred from another hospital, and he comes with some cognitive issues and a frontotemporal type of presentation. And brain MRI was done, and it's quite abnormal. Again, you see the pontine abnormality, enlargement, the distortion, the mammillary body, the distance between the top of pons and mammillary bodies reduced. We'll look at that. Numerous blood patches were not effective. Spinal imaging with MR myelogram. Again, this is a heavily T2-weighted sequence. There's no contrast introduction, and we rely on this heavily. Shows no leak in the cervical or upper thoracic region, neither diverticulum or other abnormality. Conventional myelogram and CT fails to demonstrate any abnormality, no cyst or extrathecal collections. We did a DSM for this patient, even though there was no ventral leak or anything to suspect a rapid flow leak. And I want you to, this is an AP view, I want you to focus on the top right in this region. And we do this under general anesthesia, and the patients are still and there's no motion, and it's a breath hold so that we have clear pictures. And as the contrast comes up, I'd like you to take a look at this region, which opacifies and has a very tortuous vascular type of filling. And this was an example of a CSF venous fistula, a fairly uncommon or rare type of presentation, but one that we see and recognize more and more in recent years. And that's one advantage of this technique, the DSM, which elucidated this abnormality and escaped all the other referring institutions. They couldn't find the source. And this patient was taken to the ER by Dr. Shivinka and was successfully treated with this. Another cranial MRI, similar findings. I don't think it's easy to find anything else that causes this appearance. I know Dr. Levin mentioned that it could be a tumor, but when we see this kind of optic chiasm flattening, the distortion here, there's only one thing this is due to. This is due to intracranial hypotension CSF leak condition. This patient has a right-sided subdural and meningeal enhancement. Now I'm showing this case to see the spinal imaging, which is interesting. This is a sagittal T2 MRI, demonstrates a ventral extrathecal extradural collection, and actually a dorsal one as well, so it's kind of circumferential. But you can see the separate CSF collection here. When we did the MR myelogram, again, T2 weighted without contrast injection, you see that there is abundant leak at C12 level, laterally and then posteriorly. So, after this, we did the DSM, and I want to show you this area is leaking at C12. Turns out this is not an uncommon presentation where it's a pseudo-localizing sign where the site of actual leakage is not in this site. We found it in the upper thoracic spine. However, these patients present with leakage through the skull base, C12, or elsewhere in the lumbar spine. Oh, this is a close-up of the same. Let me show you an example where DSM, digital subtraction, really shines, and that's with ventral leaks. And this patient had a known from MRI a ventral leak, and this is a lateral view. Again, this is done under anesthesia with the patient's respiration suspended for about 30-40 seconds for the duration of the injection. And as you can see, the ventral aspect of the sac, there's a communication with the extrathecal collection. And that makes it really easy to fix this, whether it's with percutaneous, if it's possible, or more traditionally, Dr. Shiving will talk about it later, surgical approach. Now we're talking about some of the leaks that are not so fast. Again, this is another patient who has a bibrachial amyotrophy, and he has a large collection in the cervicothoracic spine, ventral leak. We did the DSM, found nothing. Conventional was negative as well, and DSM was done, it came to us. And then we did the CT-guided dynamic myelogram, which involves putting the needle in the CT gantry, in the CT suite, and injecting and having rapid successive series of CT acquisitions. And from left to right, you see early and late. What you do see here, although it's not as precise as the DSM, you see that there's a gradient of increasing contrast density in the upper thoracic spine, which to us told us that the leak was somewhere in the upper thoracic spine at T1, T2 level, and we thought we found a calcified small disc, and subsequently that proved to be correct. So this is something that we do for intermediate leaks. What is this one? I think I'm going the reverse way. Sorry about that. Okay. This picture is supposed to show you the value of the T2-weighted MR myelogram and its contribution. We really do not have to do a conventional myelogram to make a diagnosis of CSF leak in this patient. The patient has not only multiple meningeal diverticula in the thoracic spine, but in the lumbar spine, you see, has this fluid seeping through many different levels through the loose epidural tissues. And the axial representation of this fluid is here along the nerve roots, epidural areas, back to the paraspinal tissues. And the patient had successful blood patch. We don't have, in this particular case, I don't have follow-up, but in other cases I've seen that when you do repeat imaging and the original leak site is fixed, this kind of fluid seepage is resolved as well. So again, it's not necessarily the site of the leak, but indicates that the overall leak condition persists in the sac. Another patient with multiple meningeal diverticulum. This presents a problem if permanent fix is required and surgery is contemplated. Where and how do you treat? Which one do you treat? Levels selection becomes important. This patient had large ones in the thoracolumbar junction, but some in the upper thoracic spine. So we ended up doing the DSM to give us an idea whether there was an earlier opacification of any of those. And based on the DSM, we decided that this, the TL junction was the responsible, not the cervicothoracic junction, and she was successfully operated with good results. Sorry, let's see. This is a young lady from the East Coast. She came over. She had, similar to the earlier case I showed, had large areas of CSF seepage in the T2 myelogram, but also largish cyst in the L4, L5, L5S1 level, which was very nicely shown on the CT myelogram. And she underwent successful fibrin glue, which we talk about later. This is another example of fistula, just to show you that we have more than one of these. A patient with small meningeal diverticula did not know really which one of this was a problem, so we did the DSM, and this is the low thoracic region. Focus here on this side, AP view. And you can see that there's a vascular connection from nerve roots, axilla, and a opacification of the epidural vein. I have some time. I want to talk about a couple of situations where I think is of some interest, to everybody, but particular interest to radiologists in the meeting. And that is, how do you deal with subdural hematoma? It's not uncommon for us to have once or twice a year a patient come in from the ER with subdural hematomas and go straight up to neurosurgical ICU and be operated on for evacuation. But occasionally we're able to catch this in advance and see that, well, maybe this patient has subdural hematomas related to CSF leak. So one of the clues is, although it's not as elegant as MRI, we do have sagittal reformations on all of the CTs that we do. And you can see there that there is some problem here in the brainstem, and the optic chiasm is kind of flat, not quite right. Follow-up MRI confirms our suspicion. There's marked brainstem distortion. The optic chiasm is coming down here, in addition to the bilateral subdural hematomas. How to deal with this is complex, and Dr. Schiving may talk about it later, but a combination of blood patch, surgery if necessary, so it's complex issue. Finally, one thing that I want to bring up is siderosis related to CSF leak. Again, once a year, maybe once every other year, a patient gets sent for tinnitus or headaches or not related to CSF leak, nobody's suspecting it, and we do our T2 SWI susceptibility weighted imaging or cranial echo imaging, which is very sensitive to old blood hemosiderin, and you see this typical zebra pattern of hemosiderin deposition in the posterior fossa. These are 12 different patients you see here, and each and every one of them was diagnosed with CSF leak eventually, either before or after. Not all these cases are incidental, but like I said, a few cases we've been able to point the clinician to the right area of investigation. So I'd like to summarize the approach. It's cranial MRI to begin with, and then myelograms, and depending on what you're looking for. The conventional CT myelogram initial investigation may be very good. It's not as good for high flow leaks, and it may show low flow leaks as far as the site detection. The radiation dose is acceptable. The dynamic CT myelogram, where you introduce contrast through in the CT suite and do repetitive CT, that may be a little bit higher radiation, but it does have its role in the intermediate leaks for some select patients, and it's been used across different centers, and we use them occasionally. DSM, and initial, I put question mark. I kind of modified Peter's table here. We tend to do DSM initially in many patients. Maybe our patient population is slightly different. We get more referrals. More and more of our patients are definite leakers, not necessarily rule out leakers. So we find value in DSM for the reasons I showed you. We occasionally find things that are not evident on conventional or MRI, like fistula. And it's excellent for high flow leaks. And radiation dose is acceptable. I was talking about intrathecal Gatto MRI. We did a whole bunch of them. We really could not find any major additional value. Occasionally we do them, but it hasn't been as successful as we hoped it would be. Obviously there's no radiation there. This MR and MR-T2 weighted myelogram is the stuff that we love, because it helps us determine the diverticula very easily without any needle insertion. And radionuclide is fallen out of favor. Let's see what else. And that's it. That's what I have to talk to you about. Thank you. I think I cut it short a little bit for questions. I know we're going to have it all at the end, but if you have any couple of questions, I think we have time for that. Yes?
Can you comment on your DSM, how many runs you're able to do, or do you do one injection and know what site you're trying to look for?
Generally, based on the pre-op imaging, pre-DSM imaging, we have a fair idea about where to look for. Those T2 myelograms I showed you show us where the diverticulum are. If there's an extrathecal collection, we know where they are, so we focus on that. In an average patient, we can cover almost the entire thoracic spine, and sometimes the bottom of the cervical spine. So we adjust that based on that. Sometimes we do thoracolumbar, sometimes thoracocervical. We have one shot. We don't do repeat shots, unfortunately. And you have to be perfect, because then if it's ruined, it's ruined. And by no means we're not perfect, and occasionally we mess up too, but you try to get it very accurately, the needle, so that there's no leakage, et cetera. Yes?
Pretty wild question, but have you guys ever done functional MRI on these patients?
Funny, you should ask that.
You fix a leak, you know?
Yeah. I have a project that's in the, hasn't started yet, and we're planning to do a functional MRI, specifically looking at the the resting functional MRI status of the brain in these patients. We're going through IRB and et cetera, but we're planning to do that. Yes. Okay.